Good morning. So, as you know, in rheumatology, we see a lot of clinical cases that have overlap with primary care because a lot of our diseases are very systemic. But you'll undoubtedly come across a case of patients with inflammation in their joints. So, I thought we could work through a case together. So, this is going to be very clinically based, and we're going to go through some clinical diagnostic criteria and tools that you can use, as well as some management issues. Just emphasizing that a lot of our diseases are systemic, so it's not just limited to the joints as well. So this is going to be very interactive. So please ask questions and find out things you don't understand. So we're going to try to go through a good history and physical, which is really the bread and butter of what we do in rheumatology. It is like a lot of our diseases are diagnosed based on clinical criteria rather than on a specific blood test or even one radiology exam. So the history and physical really does play a very important part still. There are some labs that we do. There are a whole slew of rheumatology labs that you might see on your order panel, and we can go over some of those. We're going to just go over sort of how to interpret a few radiographs looking at inflammatory arthritis. Something just to bear in mind is that arthritis can sometimes be a manifestation of a larger systemic disease. So there are some extra-articular manifestations as well. And then we'll go through some treatment and management options that you can start on even before we talk to rheumatology. So this is a patient of mine. DD, she's 54 years old, and she comes to you with like a 3-month history of worsening joint pain. She's having difficulty opening jars and door handles, and she wakes up saying that her whole body is stiff for about 2 hours. And she says it takes her a little while to warm up, but then after that she can go on with her activities. She's noticed that it's harder to get her rings on and off, and she feels that her shoes are getting tight and uncomfortable. And she's tried over-the-counter Tylenol and Advil without too much improvement. She has a past medical history of hypertension, which she controls with her diet. She's had breast augmentation in terms of surgical history. She does actually have a family history of a twin sister with rheumatoid arthritis who actually passed away from interstitial lung disease complications. Her mother has hypertension and her father heart disease. She is a smoker, but she quit 10 years ago, and she drinks, she says, socially. Denies any illicit drug use. And she's only taking Advil or Tylenol as needed. No known drug allergies. So usually with rheumatologic cases, we do a complete review of systems, looking at potentially other systemic manifestations of disease. So sometimes we ask for things like alopecia or other skin changes, Zika symptoms, which is like dry eyes and dry mouth, and it's usually very clinically apparent. So they can barely make tears when they're sad, or they have to use eye drops all the time. You can ask them, can you swallow your food comfortably, or does like the idea of eating a cracker without water just like bother you a lot? We can ask about their dentition too, because with poor saliva production, they may have a lot of cavities forming. So those are some clinical questions you can use to tease out whether or not they have true Zika symptoms. Photosensitivity is often seen in a lot of our autoimmune diseases. So people will say, when they're out in the sun for more than 10 minutes, they break out in hives, or they feel really itchy, or they may get nauseous and headache. So that might be an example of photosensitivity. Rashes are oftentimes seen in our autoimmune diseases, and there are some rashes in particular that are associated with inflammatory arthritis, so it's important to ask about those. And Raynaud's syndrome, which is a vasospasm of the digital arteries. So vasculopathies can oftentimes be seen in the context of some of our connective tissue diseases. So you might see a whole lot, which is why our review systems goes from head to toe. There are many more questions that we ask, but these are some of the more pertinent ones that you might see in relation to inflammatory arthritis. And then you also want to ask in your history about risk factors for other diseases that can cause an inflammatory arthritis. So inflammatory arthritis isn't always just caused by an autoimmune condition or inflammatory condition. It can be caused by infections as well. There's always this tension sometimes in the inpatient service between rheumatology and infectious disease, whether this like fever or this joint pain is coming from an infection or something autoimmune. So there are some infections that can cause an inflammatory arthritis as well. So a good sexual history is important to take. Things like gonorrhea, chlamydia, or even syphilis can cause an inflammatory arthritis. IV drug use to assess for risk factors for endocarditis, because that can cause an inflammatory arthritis. Again, a history of transfusions. Childhood illnesses like rheumatic fever might be something you want to assess. And then close contact with young children. So strep bacteria, parvovirus, other infections that have been known to cause an inflammatory picture that looks a lot like rheumatoid arthritis. Yeah, so a lot of our time is spent taking a history. So in terms of our patient, she actually does report some Zika symptoms. She's reported that her dentition has become a lot worse. She's had to get a few cavities filled. She's always drinking water. And she says, yeah, in the winter months, she is seeing that her fingers are turning blue, purple, pale, and they get really numb as well. In terms of the sexual history, she's been monogamous with her husband for 16 years, denies any history of STIs, denies drug use, transfusions, had an unremarkable childhood. She does have a 12-year-old son who is in school, but he's relatively healthy and has not had many strep infections or other illnesses recently. So then you move on to your physical exam, and these are some examples of hands that you might see on your patient. Can anybody guess what her hands might look like? Or what these pictures show? Which set of hands would belong to her? There's this one. This one is at the top right. And this one. Who thinks this one on the right? Left? Yes. So yeah, the top left. I don't know if you can see, but there's some very subtle synovitis, swelling and puffiness around the PIP joints over here. You can see the skin is a little bit shinier. There's some whitening around the PIP joints. And the DIPs are relatively spared. It's hard to make out if there's any swelling on the MCPs, maybe a little bit at the second MCP. So this is this would be an example of synovitis in the small joints of the hands. Usually they're tender if you press on it. And if you actually squeeze your own PIP, like laterally, you can exert a fair amount of force without causing pain. So if you squeeze on a patient's hand and they say it's tender and painful, that can be a clinical indication that there is actual inflammation there. But sometimes in the early stages it can be pretty subtle. So it's just important to recognize what's normal and what's not. The hands over here, anybody know what they are? This looks like, this is osteoarthritis. You can see there is also some appearance of a bony enlargement around the PIPs. So if you're not familiar with it, sometimes people will look at this and say, oh, they're swelling at the PIPs. But if you actually push on it, it's more bony overgrowth than like spongy synovitis. So it's so this over here, the synovitis here is much softer. Sometimes it can be warm. Whereas here over here on the osteoarthritic hands, this is more bony and hard, so it's not doesn't feel very spongy. It's actually deposition of new bone or osteophyte formation of the PIPs. And also you can see that there's DIP involvement here, so there's bony enlargement of the distal interphalangeal joints. And rheumatoid arthritis almost never involves the DIPs. So if there's a lot of DIP pain and swelling and DIP involvement, you want to think away from rheumatoid. But in osteoarthritis, it's commonly associated with DIP involvement. You can see also here there's a little bit of subluxation, so the joints are starting to turn, which you can see in both entities. But again, DIP involvement is usually seen in osteoarthritis. And then the bottom hands. This is a gouty hand. So this large deposit over here is a tophus, which is basically a nodule full of uric acid. If you were to stick a needle in here, this white milky substance would come out looking like chalk. So if there's any question, you can do that. Rheumatoid nodules will also look similar, and they can be seen on the dorsal surfaces of the hands, but when you aspirate it or when you try to extrude the material inside, it's usually bloody, sometimes necrotic material will come out. It's not this white chalky urine that comes out. Also in gouty arthritis, there's an asymmetric distribution of involvement. So this finger is relatively spared, whereas you'll see lots of gouty deposits on the hands that are sort of interspersed within the fingers. Here there is also some DIP involvement as well. So in gouty hands, it's asymmetric, whereas in rheumatoid, the distribution tends to be more symmetric. And again, these nodules, if you were to aspirate them, you would get some urate. And so in the rest of her clinical exam, her vitals are relatively stable. She maybe is a little tacky. She has some dry mucous membranes, and you can see that there's some poor dentition. Her lungs were clear, abdomen was benign. And on her musculoskeletal exam, she has some pain rotating both of her shoulders. She has some tenderness at her wrists, her MCPs, her PIPs, and some swelling at her PIPs. It's a little subtle, but it's there. She says she has trouble getting her reins on and off. And then she also has pain and tenderness when rotating her ankles bilaterally. Her nerve exam is pretty intact, and there's no rashes that you can see. No rashes or nodules on her skin. So what do you tell her? There's no cure, which is actually what a lot of my patients say, and which is what delays their care sometimes. I think there's really no point in treating it. Start steroids, which most people will do. Check an ANA, or a rheumatology panel, which is something we see a lot, but we'd like to discourage because the ANA test is notoriously nonspecific. About 1/3 of the population will have a positive ANA without having any sort of clinical disease. And the rheumatology panel is quite extensive and can be can incorporate a lot of different autoantibodies that may not have anything to do with your patient's clinical case. So a lot of times people come to us with a positive test with a lot of anxiety and they actually don't have anything clinically on exam. So really it's trying to tailor your studies to what your clinical suspicion is because there can be a lot of false positives and can create a lot of undue anxiety. We get this also, so we're happy to help all the time, but it would be nice if we had a clinical question and start our workup. So what would you guys do if you were to start a workup? Or what labs would you do? CCP? Our level? Yeah. So CCP and RF are probably the most common serologies we've seen with people who have a suspicion of inflammatory arthritis. The rheumatoid factor is a test that is non-specific. The sensitivity is about 66%. So there are definitely patients who have rheumatoid arthritis without positive rheumatoid factor. The specificity is only about 90%, 90-91%. Other things that can give you a positive rheumatoid factor are any sort of chronic infection like tuberculosis, hepatitis, particularly hepatitis B and C have been known to have very, very high rheumatoid factors, some even higher than in rheumatoid arthritis. We've seen them in the 600s, like even over 5,000 with Hep C. Lymphoma has been known to cause a very, very high rheumatoid factor, as well as Sjogren's disease. So rheumatoid arthritis isn't the only thing that can cause a rheumatoid factor. CCP antibody, however, is very specific. There's really not anything in the literature that has been shown to cause a positive CCP other than rheumatoid arthritis. And it's not necessarily a marker of activity because there are patients patients who are walking around with a positive CCP antibody who don't have active rheumatoid arthritis, but if you do find this antibody in your patient, it's likely that they will, at some point in their life, develop inflammatory arthritis. By ordering both tests, you really increase your sensitivity and specificity. We also like to check inflammatory markers because, as I said, a lot of our diseases are systemic, and so you may see of ESR and CRP. Again, they're not specific to rheumatoid arthritis. You can see them in infection, stress, anemia, but it does help your diagnostic workup. And then, as we mentioned before, a lot of other things can resemble an inflammatory arthritis, so we usually check some infectious serologies too. So if they've been exposed to hepatitis, HIV, recent parvovirus exposure, strep bacteria. So we might check on some infectious serologies too, depending on the clinical presentation and the history. Our patient actually had a very high CCP antibody, though she had a negative rheumatoid factor. She had elevated inflammatory markers as well, and her infectious marker was negative. So we mentioned we check radiographs. Anybody see anything particularly special about these radiographs?
But do you always check radiographs? Like, do you have a new diagnosis? I know you don't need it for the diagnosis, but do you always check?
We don't always, particularly because if their clinical exam is, say, very unremarkable, and there's no real sign of joint deformity or limitation in their range of motion, it's actually unlikely you're going to find too much on plain radiographs, because plain radiographs really show more advanced disease. If there's erosion or if there's subluxation of the joint, it can sometimes give you some subtle hints, like in this one. So if you're having some trouble figuring out if there's active inflammation or if there is potentially a deformity that's related to RA, you might want to get one just to help clarify. But they are definitely more helpful when the disease is more advanced. This radiograph would be an example of very, very early rheumatoid arthritis or inflammatory arthritis, and actually you won't be able to see very much in terms of erosion or joint damage. But if you look really closely around the joint margins, some people describe this as periarticular osteopenia. So you'll see that it's more lucent around the joint margins compared to the shaft of the bone. So this type of periarticular osteopenia you would see in any type of inflammatory arthritis, and it's a very, very early change. So if the radiologist calls it periarticular osteopenia, that's a pretty good clinical suspicion that there's some inflammatory process going on. Not all radiologists will call this. I mean, it depends on how they read the film and penetration of the film, but if they are able to differentiate, it's a pretty good. Again, you can see some periarticular osteopenia, and then this is a little bit more advanced, but they're starting to have some carpal crowding at the wrists. So this area of the wrist, the MCPs and the PAPs are areas that rheumatoid arthritis involves most commonly, and changes at the wrist can occur early on too. You might see what's called carpal crowding, or a loss of the joint space margins, and then eventually in late stages there can be fusion of the carpal bones, leading to loss of range of motion. This is a set of rheumatoid arthritis hands as well, and there are erosions on this film, but they're quite hard to see sometimes if you don't know what you're looking for. It's probably impossible to see on this slide, but if you look closely, this is the right hand. Over here you'll see this tiny erosion. We call this a marginal erosion. Most of rheumatoid arthritis erosions are away from the joint, so on the side here, you can see it both here. This is at the MCPs. Marginal erosions are usually seen in rheumatoid arthritis. Central erosions, if they're over here in the middle of the joint, we usually see in osteoarthritis, or erosive inflammatory osteoarthritis, which is when you see marginal erosions, or when the radiologist calls it marginal erosions, we usually think rheumatoid arthritis. Gout can also cause erosions. Gouty erosions are away from the joint, so we might see them down here, more proximal aspect of the growth. And obviously, we talked about how X-rays are not super sensitive for early disease, but you can get MRIs. There are other imaging modalities, like you can use to tease out whether or not this patient has active inflammation in the joint. MRIs can definitely pick up inflammation at an earlier stage, even before there's been bony cortex erosion. You can see here that there is starting to have some bone marrow edema in the bony cortex here as well. And this is a T2 weighted image. This is synovitis, so the fluid is bright within the joint margin. There's some scattered erosions here in the carpal bones as well. So these may not show up on X-ray, but you get an MRI, which insurance doesn't always pay for. You might be able to detect it earlier. And we are increasingly using more ultrasound as well to help us determine if there's synovitis or if there's joint inflammation. This is an ultrasound of a finger. So it's looking at between the PIP and the DIP, actually. Using the Doppler signal, you can see that there's a little bit more vascularity too. So this hyperemia is sometimes what we see in an active joint that's inflamed. There's also some bowing of the joint capsule, so this is what causes the swelling. But underneath it all, you can see that there's a lot of vascularity. So you've done your physical exam, you've taken a good history, you've ordered a few labs and x-rays, so while you're waiting for that, this is the classification criteria from EULAR that we sometimes use to help us diagnose rheumatoid arthritis. So it takes into consideration which joints are involved, whether they're large joints, whether they're small joints, and how many joints are involved, and then some of their serologic testing, symptom duration, and acute phase reactants. So if you get a score of greater than 6, it's pretty much all right. Yeah. Usually we talk about 3 times above the upper. Yeah. 21 is kind of cheap, and it depends on age too. So what if the score is less than 6? Then you can actually follow them over time to see if they might fulfill it, or you can actually ask about in their history whether or not they did have some of these criteria in the past. And if they can still make a score over 6, you might still diagnose them. So in terms of joint distribution and joint involvement, any swollen or tender joint counts, but it depends on which joint. So we exclude actually the DIPs in our joint count, because again, we don't really see that in rheumatoid arthritis. We also exclude the first MTP joint, that's usually seen in gout or OA, and the first CMC joint, which is right here, the basic joint of the thumb, that's also seen more in OA. You can, if you don't see it on your exam, but you have evidence of it on the ultrasound or MRI, you can use that as part of your joint count. A small joint is your MCPs, your PIPs, and your MTPs on the toes, excluding the first toe, your thumb, IP joint, and the wrists. And large joints are your shoulders, elbows, hips, knees, and ankles. People often ask about neck pain or spinal pain. Rheumatoid arthritis doesn't often involve the entire spine. It can cause some pannus and inflammation at the cervical spine, causing C1, C2 subluxation. That's a known complication of rheumatoid arthritis disease. But generally in the thoracic and lumbar spine, we don't see a whole lot of joint involvement. So we don't really include the spine as our joint count. But the neck is something that we do pay attention to, especially in patients with advanced rheumatoid arthritis, because of the potential subluxation at C1, C2. So if those advanced rheumatoid arthritis patients need surgery or need to be intubated for any reason, they should actually get dynamic neck films to see if there is subluxation because the anesthesiologist would need to know that before they intubate them. If they hyperex someone too much, it can cause vertebral artery dissection. If they have more than 10 joints, you get 5 points. At least one small joint has to be involved, and then you can actually include some other joints too. So people oftentimes forget the jaw, TMJ, the sternoclavicular joint, the AC joint, are other joints that we shouldn't forget. So serologies, we look at 3 times above the upper limit of normal. And our patient got 14 points based on her clinical exam and her history, and her serologies and inflammatory markers. So she has RA. So now what do we do? What would you start with? Methotrexate? Plaquenil? These are all, so naproxen, NSAIDs, people use a lot. They are only palliative for symptoms. It's not considered sufficient to really treat the underlying inflammation. Prednisone, we do use a lot in rheumatoid arthritis and inflammatory diseases, but 1 mg per kg is an incredibly high dose. And so for rheumatoid arthritis patients, you normally don't need more than 20 milligrams of prednisone, and usually their joints respond very well. So 1 mg per kg is actually very extreme. Plaquenil we use all the time. Rheumatologists some say they want to put it in the water. It's very safe usually. There are very few side effects. It's not an immunosuppressive, which is what a lot of our patients really like, and it's not a steroid. It actually might help with blood sugar management sometimes too, and it has a small anticoagulant effect. But really very well tolerated. The only problem with Plaquenil is that it takes a very long time to kick in, like almost an order of 2 months. So if a patient's in excruciating pain, it might not be something to start with. Methotrexate is the gold standard for rheumatoid arthritis currently. It is a disease-modifying agent. It's also technically a chemotherapy at high doses. We use it for lymphoma and leukemia. But at the doses we use, which are minuscule compared to them, it has been used to treat all kinds of inflammatory arthritis with very good success. And then Enbrel, or etanercept, belongs to the class of biologics. It's normally not a first-line agent, but increasingly people are using it earlier and earlier on if there's been no good response to initial therapy. So this patient opted to start off with Plaquenil and methotrexate. We did methotrexate because she was actually having a lot of pain and a lot of swelling, and we added Plaquenil on just because her high CCP antibody. So the high CCP antibody sort of presents a more aggressive disease. So we wanted to make sure that she was on very good treatment. But because it takes a long time to kick in, we have the methotrexate on board as well. And naproxen we just gave her for symptomatic relief.
Is Plaquenil actually Lebar?
Yes, it is. Yeah, we consider it. So we went over some of the NSAIDs for symptomatic relief. Our DMARDs include prednisone, Plaquenil, hydroxychloroquine, methotrexate, and muflunomide, which is a RAVA. Muflunomide is very similar to methotrexate. It's used to be used to treat worms. It's an antifungal thing. But it is slightly immunosuppressive like methotrexate, and you do have to watch the liver effects. We sometimes do use immunosuppressives like Imuran, Cellcept, cyclosporin, but usually we reserve those for patients who have extra-articular manifestations like organ involvement, such as lungs or eye or skin. And then the full class of biologics is something that we're using a lot more now. This has definitely changed the way rheumatologists practice medicine. Previously, before biologics were available, all we had was the first 3 categories, and people, about 30% still progressed on to deformity. So with the advent of biologics, we've been able to really slow down radiographic progression, and in a lot of cases, place patients into clinical remission, which is something that we never used to do before. So this has really changed the way we practice how we treat patients. Obviously, there are some side effects and risks to all these treatments, which you have to take into consideration when you do your history taking. I'm sure as internal medicine bacteriologists is taking a very, very long history, so depending on their comorbidities, you might want to stay away from some other things. A lot of our patients have GERD, so NSAIDs aren't a great idea.
So I have a seronegative RA patient that's on rituximab, and she was on depot shots and got pregnant. Have you ever heard of that? Yeah, because that was a little.
Yeah. So pregnancy is very tricky in some of our patients. Interestingly, in rheumatoid arthritis, mainly seropositive rheumatoid arthritis patients, the vast majority of them, like 90% of them, go into clinical remission when they get pregnant. So you can probably take them off of their DMARDs, their steroids, when they get pregnant, because for some reason pregnancy really helps with rheumatoid arthritis.
But this is the other problem. She
She don't want to. So I'm wondering, do you like? Like, what do you? Have you heard of like the immunosuppressive interacting
With Depo?
Yeah.
Oh, I have not.
Okay. It was just because we were.
It is a concern with diabetes, right?
I'm not well versed. Yeah.
We do, with the exception of Plaquenil, we do actually recommend people take birth control. We do a lot of like pre-pregnancy counseling with our patients. Most of these medications are not compatible with pregnancy, with the exception of maybe Imuran and cyclosporin, but like the other and hydroxychloroquine. Those are the three that we are still able to use for pregnancy or people who are planning pregnancy. For example, the flutamide, Arava, we don't use it when you're childbearing age at all, because it takes like 2 years to chelate it out of your system. And the biologics, we're really not sure about. There's been no great data on pregnancy, but some high-risk OBs and rheumatologists are using golimumab golimumab because it's an anti-TNF inhibitor, but it's pegylated, and it may be way too large to cross the placenta. So most people, if they do need to absolutely need to use a biologic, they might go with either golimumab or Remicade because they are the molecule is so large. But we don't really have a lot of data on the other ones, so we don't have anything on rituximab. But nobody would really use it intentionally in a patient who is trying to be pregnant. So depending on their comorbidities, whether they have GERD or diabetes or underlying lung disease or a history of tuberculosis or hepatitis, you want to be very judicious about how you use your medications. So our patient, she was started on Plaquenil, methotrexate, and prednisone, and then we were able to taper the prednisone to 5, and she improved a lot. She had several flares over the next year, and we increased her methotrexate to 20 and gave her like short bursts of prednisone tapers. And she did fairly well. What do we do now? Do we just keep her on this regimen? She's still on like a little bit of prednisone. Increase in methotrexate to 30. Sulfasalazine would be a reasonable choice too. So Plaquenil, methotrexate, and sulfasalazine is what we call triple DMARD therapy. It's a regimen that has been studied against methotrexate plus a biologic and seems to be able to have the same clinical results in both arms. However, it takes a little bit longer for the patient to get into clinical remission in triple DMARD therapy compared to that biologic.
But the cost is like incredibly.
Yes.
Yeah,
the cost is like extremely high, and so is the work of talking to an insurance company and getting prior authorization. So sulfasalazine or Androl would be appropriate choices in this case. Methotrexate we don't use above 25 milligrams. We've seen more toxicity and not increased efficacy at higher doses than that for arthritis. IVIG we don't often rituximab we can use, but that's usually reserved for our patients who have very aggressive refractory disease. So she added Enbrel, and she went into clinical remission. She felt great, had no symptoms, and probably because of that, she stopped coming to school and was lost to follow-up. 1.5 years later, she admitted that she stopped all her meds and was currently flaring. She had 2 hours of morning stiffness, pain and swelling in her joints, and she fell 3 times in the last 3 weeks. So her joints have progressed. This is not actually her hand, but this is what you might see in advanced rheumatoid arthritis. So you can see that there's synovial proliferation at her MCPs. There's a little bit of a swan neck look to this 4th finger over here. So there's hyperextension at the PIP with flexion at the DIP, looking like a swan neck. You can see that on the 2nd and 3rd fingers as well. But there's a lot of synovial proliferation as well as in the wrists. Exam, also a little bit tacky, poor dentition, lungs were clear. There's synovitis over a lot of her joints, small and large. And then on her neuro exam now, you notice that she has a foot drop at the right ankle. So we get an EMG and a nerve biopsy eventually, and it looks like she actually has a neuropathy. And on the biopsy, there's mild perivascular inflammation. So this actually is consistent with a mononeuritis multiplex, which is not a very common complication of rheumatoid arthritis, but it's well described in the literature. And she happened to have it. So now what do we do? She has joint and nerve involvement. We stick to Enbrel and give her more serologies. So we can up her steroid again to a moderate dose of 20. We can blast her with steroids and give her like a pulse, which, to be honest, rheumatologists don't like pulsing. You'll see renal specialists pulse your patients much, or pulmonary specialists pulse your patients much. I mean, we use it all the time, but the doses we use are actually minuscule compared to other specialties. So pulsing is not something that we like to do. We can restart her biologic. Restart methotrexate. We can go with cyclophosphamide, which is really high dose chemo, cytoxan, or rituximab. So for acute flares, nothing else works as quickly as steroid. So in this case, we actually do pulsar. When it starts to involve other organs other than the joints, like lung and skin, sometimes the kidney, we do use very, very high dose steroids. 20 milligrams is what you would use for a joint flare, but when it involves other organs, particularly like the nervous system, they actually need higher doses of steroids. Biologics, we also have not studied in neurologic manifestations of RA. And in fact, the anti-TNF inhibitors may cause a demyelinating syndrome in some patients. So we would stay away from anti-TNFs. So we opted for cyclophosphamide. We wanted to be as aggressive as we could in this patient because it looked like she was having extra-articular manifestations. Cyclophosphamide is chemotherapy, and there are risks in and of itself. We try to limit the cumulative dosing. There is a risk of hemorrhagic cystitis, ovarian failure, secondary lymphoma in these patients. She was no longer thinking of having kids, but we wanted to save her nerves. She got cytoxan and a pulse, and after just 2 doses of the cyclophosphamide, she was able to dorsiflex and ventriflex her right foot again with full strength. And her joints were very well controlled. She only got 1 more dose of cytoxan, and then we stopped it because she seemed to be quite better. And we restarted some of her other DMARDs, like her plaquenil and methotrexate, and continued to keep her on prednisone taper. She did pretty well for 3 months, and she came back, and her joint pain was very well controlled. She had half an hour of morning stiffness, so we usually gauge 30 to 40 minutes as an acceptable time frame for morning stiffness. People with osteoarthritis, people who have injury or exercise, they can get up to 15, 20 minutes of morning stiffness without it being clinically significant. But if they're talking about 30, 40 minutes, then we start to think that there may be some underlying inflammatory process going on. No more neuropathy. Her exercise tolerance, though, has decreased now, only to 5 blocks, whereas previously it was unlimited. And she says she's short of breath when she's walking around, going upstairs, and she has had this dry cough. Because she had a smoking history, we got a chest x-ray, she had no acute pulmonary disease, no focal consolidation, but she kept having symptoms, so we got a chest CT, which showed these areas of patchy ground glass opacities in the bilateral lungs. No traction bronchiectasis or could be pneumonitis, methotrexate pneumonitis is a possibility. PCP, she is immunocompromised. Yeah, so those are all potential differentials. Methotrexate pneumonitis is something that we see rarely. Usually you see it earlier on in the course of treatment, though. So they usually have symptoms within a few weeks of starting methotrexate. People are very sick, they're febrile, and they usually cough up this frothy sputum. On BAL, you'll see this like white foamy exudate as well. And they typically have a lot of chest pain when they have methotrexate-induced pneumonitis. PCP, you know, I would expect them to be febrile too, but because she's immunocompromised, we definitely have to put that. And then rheumatoid. So she actually was diagnosed with ILD, interstitial lung disease, related to her rheumatoid arthritis based on the radiology finding. They didn't think that it was a consolidation that looked like PCP. And again, clinically, she was on methotrexate for now 2.5, 3 years. So now what are your treatment options? 20 milligrams, probably insufficient, right? We're talking about additional organ involvement now, so we might call serologies. Cyclophosphamide, so more chemo, rituximab, Remicade, so we opted to go with high-dose steroids once again because she was pretty acutely ill, and we gave her more Cytoxan. She seemed to respond to it well in terms of her neuropathy previously, and she'd only run 3 doses, which is actually a very low dose. You wouldn't be wrong in giving this patient rituximab either. That's been used for extraarticular manifestations of RA, and it's been used in certain other entities that have interstitial lung disease involvement. Remicade, again, we probably wouldn't use it. It's not been studied in interstitial lung disease. So despite getting that regimen, she actually had several exacerbations of her interstitial lung disease. She remained on really, really high-dose steroids, but was unable to wean down her steroids, and she eventually had to get a tracheostomy. Her arthritis never came back on that steroid dose, neither did her neuropathy, but she actually expired. She actually passed away because of her lung disease, despite having very, very aggressive treatment. And it's telling her twin sister actually died of the same causes. So there's some genetic predisposition to having a very aggressive form. So this case just wanted to highlight some of the subtle findings of rheumatoid arthritis in the beginning and how you would work it out. Really the importance of taking a really, really good history and forming a differential. Some of the laboratory studies that we use, RFCCP is very important, but not to forget the other mimickers of rheumatoid arthritis like infection, and to start DMARDs early on the disease. Like naproxen and some low-dose prednisone really is palliative only, but doesn't really change the course of their disease. So getting them on something like methotrexate and Ghaw or even a biologic soon is really important to potentially decrease the complications of the disease. And then always be careful to not forget the extraarticular manifestations of RA, because it is a systemic illness and can potentially have other complications of this patient. So she was an extreme case, but definitely like the joint disease is one thing, but when it starts to involve other organs, we do need to be much more aggressive.
Yeah, the patient who, like, we have a patient that was on methotrexate and did well and then stopped it, but clinically did well and was asymptomatic. Is there utility in keeping one routine ward, or can you just walk through?
Yeah, so we are trying to approach a lot of our arthritides similar to how we treat malignancy now. So we treat them really aggressively up front, and if we can put them into clinical remission, we try to keep them in clinical remission for at least like 6 months to a year. If they're able to be well controlled for a time, again, 6 months to a year without any symptoms, we actually have been tapering people off of their medications and monitoring them off medication. There have been some studies in Europe looking at withdrawing like biologics, like people who've gotten TNF inhibitors and other